Okay. Well, welcome. Happy afternoon. We're excited to have you here for this particular session of the 2025 Culture of Data Conference. Thank you all for joining us. My name is Ann Hill. My pronouns are she, her, aya, and I will be moderating this session for this afternoon. We also have Stephanie Boltema, who will be our tech host. She's managing the Zoom and making sure that the tech is running smoothly. And to be fair, we could not do it without all of these volunteers that have participated in today's conference and tomorrow's conference too. So currently you're all muted now, but if you do have a question during the Q&A session, please feel free to unmute, or if you'd feel more comfortable, you can also use the chat if you have any questions about anything or if you'd like to talk to the speakers. If you feel comfortable doing so, please add your pronouns to your Zoom name, and you can do that by clicking the three dots on your video square and selecting Rename. For this particular session, we have one presentation that's going to go approximately 25 minutes, and then there will be some time afterwards, about 10 minutes for question and answers. We're really excited to be able to listen to our presenters. We're going to turn it over to Gerard Cozy and Kimberly Blackhorse to present Strength and Resilience, Incorporating Indigenous Specific Social Determinants of Health when working with an AIAN data. Kimberly and Gerard, the floor is yours.
Thank you, Stephanie and Ann, for your support. Good afternoon. Today, I have the pleasure to start us off with this presentation, Strength and Resilience, Incorporating Indigenous Social Determinants of Health while working with the American Indian Alaska Native data. We appreciate your time to listen and to learn about our presentation and its application to our work in Colorado. Before we begin, I'd like to briefly introduce our tribal relations team. We are housed in the Office of Health Equity at the Colorado Public Health and Environment, often known as CDPHE. My co-presenter and colleague, Gerard Cozy, is a member of the Métis Nation, and at CDPHE, he is the Tribal Health Specialist. I, Kimberly Blackhorse, am a citizen of the Navajo Nation, and at CDPHE, I hold the title of Tribal Health Data Specialist. Our team is led by Rachel Bryan Acker, a citizen of the Kagani Haida Tlingit tribe, and is the tribal liaison for CDPHE. Now that I have introduced our team, let's move forward to the learning objectives. So this presentation starts with the introduction of the Indigenous and Social Determinants of Health, which uniquely impacts the Indigenous tribal community and its intersectionality with social determinants of health. Next, we will identify what we have learned about, which is how the Indigenous determinants of health have an important relationship to tribal sovereignty and tribal data sovereignty rights, and its usefulness when partnering with tribal communities. Then we will wrap up with some actionable takeaways, which we have learned that best supports the health of the Native American Alaska Native population in Colorado. And we hope these actions will help ensure that the conversation that we are having today just doesn't stop here, but leads to meaningful change in our state. One last thing before we begin, it's a land acknowledgement. We acknowledge and honor the land in which we live, work, and play are the ancestral homelands of the Ute Mountain Ute tribe and the Southern Ute Indian tribe, who are the longest continuous inhabitants and the original stewards of the land in what is now known as Colorado. We honor the additional 48 tribal nations that call this land home. We recognize the terrible forcible removal and genocide that has occurred, which has led to the current situation on how the land is being used today. And it is our hope that today and the days to come, that the presentations we develop and the actions we take demonstrate our utmost respect and gratitude to all tribal nations and the ancestors of this area. We hope these actions will benefit tribal nations and tribal entities by affirming the sovereignty of all tribal nations throughout the United States. And with that, I'm going to pass it over to Gerard to start us off.
Thank you so much, Kim, and thank you so much for that beautiful land acknowledgement. I'd like to provide a quick caveat for everybody. I'm sure you've noticed that my video isn't necessarily on. I was in the midst of moving my laptop to a quieter space, and of course, a casualty of that move was a textbook landing on my camera. So I apologize, but this is what you're going to see. But hopefully it doesn't take away from the content that I'm about to discuss about Indigenous social determinants of health. But before we talk about the Indigenous social determinants of health, I'd like to mention the universal social determinants of health. Now, I'm guessing the majority of everyone attending this presentation has either heard of or worked with these in some way, shape, or form. So I'm not going to go into detail about each and every one, but it's important to note that these are factors that influence the health outcomes in which people are born into, grow up in, and age into. And just because we are focusing on the Indigenous social determinants of health today does not mean that these factors are no longer important or that they don't impact American Indian and Alaska Native communities as well. You see, Indigenous social determinants of health do not supersede or work outside these universal determinants. Instead, their framework, which was developed by the National Indian Health Board, expands upon and operates in tandem with the universal social determinants of health. And they do so to dive deeper and examine the unique cultural, historical, and social contexts that have shaped the health outcomes of Indigenous communities since colonization. And to do so effectively, the framework divides the determinants into categories. There are the most immediate determinants, things like physical environments. There are structural factors like healthcare systems and community supports. And lastly, there are big picture influences, things like colonization and tribal sovereignty. Then, of course, to further confuse you, these all depend on the context in which they appear as well, because these factors can also be subcategorized as risk factors, like barriers to healthcare, or protective factors, like cultural continuity and strong community connections. And understanding this dual nature is key to addressing American Indian and Alaska Native health disparities and supporting AIAN health in a meaningful way. And hopefully this image here helps. Only the point of this slide isn't necessarily to provide you with a comprehensive list of the determinants. Instead, it is supposed to provide you with some of the specific Indigenous determinants of health, like cultural and linguistic extinction, environmental stewardship, and institutional violence and marginalization, and demonstrate to you how each of these represents a critical piece of a larger picture. You see, unlike the universal social determinants, these determinants do not operate in isolation of one another. For example, the loss of land and displacement ties directly into economic instability, which can cause limited access to resources like healthcare, education, and housing. In turn, Indian boarding schools have caused historical and intergenerational trauma within these communities, impacting their mental health. And since many reservations have inadequate mental health care access, these issues continue to persist today. And as we discuss these determinants in more depth in the next section of our presentation, let us remember the dual nature I spoke of on the last slide. These determinants can either support well-being or contribute to risk, depending on the context. And they are all interconnected. Understanding this interconnectedness is essential to improving the broader health landscape that exists in Indigenous communities. Now, with that said, I'll go ahead and pass the mic back to Kim so that she can provide some background into what I've shared here and provide a deeper overview of the Indigenous social determinants of health for you.
Thank you, Gerard. Let's continue with the overview of Indigenous social determinants of health. So, the Indigenous social determinants of health is a larger framework that considers the cultural connectedness of the Indigenous people. This framework approaches health with the lens of equilibrium to spirituality, traditional medicine, biodiversity, and the interconnectedness to all that exists. This framework is covered with an indigeneity umbrella that encompasses generational knowledge, traditional spiritual practices, and values that connects people to each other, to the land, and the space in between. This umbrella is all Indigenous information, or considered Indigenous data, which is all applicable under the Indigenous data sovereignty and governance. That means tribal nations have the right to govern the collection, the ownership, the stewardship, the management, and the application of their own data, as it is related to the digital and data footprint of the people, the land, and the resources. The Indigenous determinants of health can be best described in three categories that is represented in the three distinct colors in this image. Starting on the left are the determinants related to intergenerational holistic healing and is represented in yellow. Indigenous application of culture are presented by the red, and the planetary health is shown in green. These three main indigeneity concepts can be interconnected with the social determinants of health. We have learned when addressing health disparities and health inequities, especially for the Native American, Alaskan Native population, it is vital to include Indigenous determinants of health because it is culturally adaptive, it is inclusive to tribal Indigenous perspectives, and is arguably, it aligns with the public health approach of primordial prevention because the Indigenous social determinants of health addresses the root cause of health problems for the Native American and Alaskan Native population. Furthermore, it can be useful in addressing chronic disease in the population because this framework addresses the root cause of being disconnected from the Indigenous culture because of the effects of colonization. It provides the indigeneity framework and highlights protective factors that re-indigenize health strategies to be culturally inclusive. It supports the reconnection with intergenerational holistic healing, and it also takes into account the personal connection with Mother Earth and all our strength-based approaches. In addition, here we have a chart that briefly summarizes the Indigenous determinants of health and recommendations delivered by the National Indian Health Board, NIHB, to the United Nations in April of 2023. This chart highlights three main categories as mentioned from the previous slide. There are a total of 33 related determinants that are categorized as health protective factors and risk factors. To provide a brief description, the concept of intergenerational holistic healing takes into account 6 protective factors related to the intergenerational approach and application of Indigenous ways of knowing and practicing that addresses the whole person. This includes the mind, the body, the spirit, and the familial and community connectedness, the reciprocity with the planetary biosphere, and the connectedness to language, which all protect against the 7 risk factors related to the historical mistreatment that has caused intergenerational trauma as Indigenous people who were forced to assimilate to a colonized system. That has and actively disconnects Indigenous people with their connection to the environment. The health of Mother Earth provides 5 protective factors that are related to the reciprocity of planetary health and cultural practices. The health of the people are synonymous with the health of the land. Thus, the protective factors are a source of healing. The indigeneity lens provides a balance of equal exchange with the earth to source Indigenous food systems, traditional medicine for healing, and access to clean and drinkable water, all of which address the 8 risk factors related to the exclusion of planetary health, which has led to climate change. The last column on the right is about culture. Culture is a protective factor and is related to tribal sovereignty rights. Tribal sovereignty is the inherent right of tribal nations to self-govern. That means they can establish their own governments, address the health of their citizens, and can even address how their digital and data footprint can be used, managed, or displayed, or how they choose to preserve their culture in traditional ways. Thus, normalizing Indigenous perspectives counteract the risk factors related to structural and systematic racism that are normalized in public policy, which exacerbate the racial inequities that essentially contribute to the normalization of the invisibility of the Native American Alaska Native population. Now that you have an understanding of the framework, I am going to pass it back to Gerard.
Thank you so much, Kim, for giving our attendees a much better understanding of what Indigenous social determinants of health are. But now I think it's time for us to look inward at Colorado and see how these determinants are actually impacting the Indigenous communities right here at home. But first, who are we talking about? As you've likely already picked up, we've been using the word Indigenous quite a bit already. The reasoning for this is because these frameworks and concepts are not necessarily new. And in some cases, they were developed where terminology is different than here in the United States. Therefore, we have retained this original verbiage out of respect, but would like to mention that in Colorado's case, when I or Kim use the word Indigenous, we are referring to the vibrant American Indian and Alaska Native presence we have here in Colorado. And to do that, I'm going to start by recognizing the Southern Ute Indian tribe and the Ute Mountain Ute tribe. Both tribes are federally recognized and reside in the southwest corner of the state. Beyond the Ute tribes, though, Colorado is also home to a diverse American Indian and Alaska Native population from many other tribes across the United States, with over 100,000 people identifying as American Indian or Alaska Native alone or in combination with. Their identities, their cultures, and their traditions strongly contribute to Colorado's social fabric. By respecting and honoring these contributions, we can better appreciate their role in shaping Colorado and better understand how we in the public health sector can serve them. Okay, so now that we know who we're talking about, let's kick things off by looking at some of the areas we can, in fact, better serve these communities by acknowledging some of the health disparities tied to Indigenous social determinants of health. And to start, I'll point out that according to the Colorado Vital Statistics Program, the American Indian Alaska Native population in Colorado between the years of 2020 and 2023, the most recent data we have had disproportionately higher suicide rates compared to their counterparts, which can be linked to historical and intergenerational traumas. Furthermore, when one looks at the statistics provided by the Urban Indian Health Institute, we see that in the Denver metro area, in each and every age category, American Indian and Alaska Native individuals fare worse than their non-Hispanic white counterparts when it comes to being insured, which can be connected to unemployment and educational attainment. And finally, from the state of Colorado's Health Information Dashboard, as of 2022, American Indian Alaska Natives have faced higher rates compared to other populations in regards to food insecurity. Now, this isn't just about access to food or insurance or even just healthcare access. These disparities reflect broader systemic issues like land displacement, economic instability, lack of culturally competent healthcare, and colonial healthcare policies. When we connect all of these pieces, we can start to see how health disparities, both upstream and downstream health issues, and the Indigenous social determinants of health are all interconnected. But it's not all bad news. We must remember the protective factors of the Indigenous social determinants of health. And at the Colorado Department of Public Health and Environment, we are seeing some major movement in these areas. For instance, we in the Tribal Relations Unit at the Colorado Department of Public Health and Environment have worked hard with our internal offices to consider more when it comes to data. And a great example of this at work is the work we performed as members of the Baby and You program's steering committee, a program that surveys postpartum people within the state about their pregnancy and beyond. And through formal outreach to the tribes, the assembly of a broad advisory network of American Indian Alaska Native partners, and through consultation, we've worked with the American Indian Alaska Native community here in Colorado to improve the program's survey questions and collect data on what is truly relevant to these specific communities. Furthermore, our team has also collaborated with the department's COVID-19 wastewater surveillance team to ensure accessibility and tribal ownership of tribal healthcare data. Not only were we able to successfully sign a sovereignty-affirming memorandum of understanding, outline the acceptable methods of data collection and use, we also affirmed the tribe's tribal data sovereignty by ensuring that their data appears on a dashboard only acceptable to them and select members of state staff. To make sure this data is understood and beneficial to the tribe, we provide support by connecting with them monthly to go through the numbers, make sure that they understand what is being presented and what those numbers mean to them. But the buck doesn't stop there. So I'll go ahead and pass the mic back to Kim so that she can take us through what we need to be considering as we move forward in a good way.
So before moving forward in a good way, we think partnership is always key. So I do want to give a shout out to the Baby and You coordinator, Sarah Blackwell, who is on this call today, and to Gabriela Iglesias Mendoza, who is also on this call today we partner with them with the programs that we have mentioned. So thank you, Gerard. We hope the conversation we're having today just doesn't stop here, but it also leads to meaningful change to our state. So finally, we will wrap up by sharing what we have learned. We hope that you consider these points when moving forward. We have learned it is our responsibility to respect tribal sovereignty rights. It is important for programs to coordinate with tribal liaisons on the best methods to engage with tribes and Native communities. This also means creating more space for additional voices at the table, having various voices that can provide more than one solution to address a problem. We have learned by using Indigenous research methodology principles and recognizing the Indigenous social determinants of health, our team is able to move forward and incorporate the protective factors of tribal sovereignty and tribal digital and data sovereignty rights, which has positively strengthened CDPHE's program partnership with external tribal governments. Just as Drada stated, the success we have experienced is not a one and done action. It is a continuous process. Thus, our final tidbit is one that is hard to ignore, and that is those who are working in tribal programs or organizations are wearing multiple hats. And oftentimes their projects are underfunded and probably operating at limited capacity. Therefore, we have learned to engage with intention. Their time is valuable and limited. So we have learned that our ask has to be relevant and provides reciprocity for mutual benefits for all. We hope what we have shared today just doesn't stop here, but it leads to meaningful change in our states. Now we're a polite group, so we're going to leave you with a Q&A and a thank you slide at the end. We appreciate your time and for listening to us today. So here are the slides. Thank you.
Thank you, Kimberly and Gerard. That was fantastic. I would love to be able to open it up right now to questions. We have time. So either unmute yourself, or if you feel you'd prefer to put it in the chat, you can do so as well. I would like to actually start us off then. If you guys could, in light of, you talked about historical trauma, in light of tremendous systemic inequities that are highlighted in the Indigenous Social Determinants of Health framework. I'm wondering how you're able to, especially coming from a government entity, how you're able to approach tribal partners and talk to them about being able to administer data, whether that's a survey or data collection, and then also being able to collect the data and then work with them to think about like the interpretation of it.
Kim, maybe I'll start and then you can sort of fill in any gaps that I miss. Um, so you sort of said it, coming from a government institution, obviously we have to take baby steps and recognize, the historic mistrust of governmental bodies when it comes to that. So I would say really what it starts off as is not necessarily the big questions about, oh, hey, what data do you have? What data can we collect? It's more about building those relationships. And it's getting to know the folks that are across from you on the tribal government. And it's really understanding that this is going to be a long-term project and it can't happen overnight. So that's, I would say, the first thing you have to recognize. And once those conversations start to build and you've sort of built that relationship, it's a lot of listening. It's a lot of listening to what they want, what they need, and the different protocols and principles and policies that their tribal government has in place when it comes to data, and not necessarily trying to transfix our own on top of them. Recognizing that we can't be paternalistic about this. We need to respect and recognize that they have their own protocols in place for these types of conversations. And I think transitioning from that is really taking those protocols that we hear from them and trying to infuse them into a data sharing agreement or memorandum of understanding that acknowledges what they need from us, and ensuring that our offices, our programs, our departments follow suit and have signed on the dotted line to ensure that that occurs. Okay, I'll let you fill in any gaps that I missed.
I think you covered it pretty well, Drad. But to add to that, I think we take the direction from the tribal governments in how in the pace they want to move, in the actions that they want to take. And we approach this from a partnership lens. So when we work with tribal partners, we have values that we try to stick to, and that's respecting and honoring tribal sovereignty. We practice and we encourage the programs to practice cultural humility. We also want to move in an actionable but in an ethical way, which addresses health inequities among Indigenous populations in Colorado. And we want to empower Indigenous voices and the perspectives that they have with public health in Colorado. So it's an ongoing partnership. It just doesn't end. And we're happy to be a part of it.
Yeah.
Thanks, Kim.
Any other questions? Please put them in the chat or raise your hand or come off of mute.
We also accept emotional outbursts if you want to share those too. That's fine.
That's good too. I'm wondering if you guys can share any results that have come from incorporating the Indigenous social determinants of health, or using that framework, I should say, with the Baby and Me data collection, and whether or not you've seen a difference in how you're collecting the data or the results that are coming from the data. I think that would be really interesting to know.
When it comes to sharing results specifically, I don't necessarily know if we can do that without certain permissions in place, but we will say that we have witnessed excellent collaboration with our advisory committee group, or sorry, not a group, but our advisory, broad advisory group with our partners. They have been very active in changing and making sure survey questions that are geared towards American Indian Alaska Natives are collecting information that is specific to them. And I will say that that I think is one of our greatest successes, because now that data is being collected and prior to it wasn't. So I think that that was a big one when it came to baby and youth specifically. Kim, do you want to add anything? I don't know if Sarah's still in the room. Sarah, if you want to share, not to put you on the spot or anything.
I can share a little bit. Yeah, so we started with intentional inclusion and incorporating and inviting a disproportionately large number of American Indian Alaska Native birthing people. So the data that we're collecting now, with a single year of data from our first survey, which is at 3 to 4 months postpartum, we're able to disaggregate for the American Indian Alaska Native population, as well as American Indian Alaska Native alone, and those in combination with any other race. And so we're collecting more data that can be representative. And then, as Gerard said, we're also trying to incorporate questions that are culturally meaningful for folks. So we had focus groups and a strategic planning process with American Indian Alaska Native partners to identify what other questions we should be asking. And there were certain things that we were already covering, but then um, uh, cultural strengths was and cultural connection is a direction we're planning to move in the future. We just need to do some more stakeholder work in developing that. And then also birth experience came up over and over. And we're in the process of developing a birth experience supplement right now in collaboration with partners. And then on the data sharing piece, so we publish our aggregate data tables broken down by many different demographics. And we held off on publishing the American Indian Alaska Native tables until those partners had about 2 months to review and provide any feedback they wanted, or make sure that there was nothing that could be potentially used in ways that are not intended, like to stigmatize. And then also like announcements were shared with the Colorado Commission of Indian Affairs. And then we waited for like permission to be able to publish those data. And so we delay when our aggregate tables are available to everyone publicly, but share those privately with American Indian Alaska Native partners and encourage them to share with any trusted partners. And so that's kind of where we are with some of those pieces, but we're trying to learn and improve things all the time.
Thank you so much for that, Sarah, and couldn't put it better myself.
Really, did you want to
we
add?
appreciate Sarah's partnership in this and being a collaborative partner. So thanks, Sarah.
100%. Thanks so much for attending.
Thank you both.
Any other questions then? All right, I have one more. Oh, you do? Please go,
I have a
Stephanie.
question if others are still thinking. I really appreciate that y'all talked about representation and know that can be so hard. And so I'm curious, especially when we're talking about limited capacity, resources, time, people being strapped, being asked to go to multiple tables. So I'm wondering, what guidance can you offer on how to authentically and equitably represent Indigenous voices at decision-making tables?
That is a very good question.
I think, if you don't mind, Rad, I'm gonna
Please do.
plug myself in here. I think part of having representation at the table is making sure the table is diverse and making sure that we have more viewpoints that can that can address a problem. And it's important that we have different viewpoints to address a particular problem. And the way we work when we coordinate our efforts with tribes and Native communities is we come in not with a paternalistic point of view, but an engaging partnership point of view. When we ask for participation, we don't expect participation. We want them to know that we are here to support them. And when the time is appropriate for them to come to the table, that space is held for them. We also encourage cultural humility when everybody is at the table, to practice cultural humility and to recognize tribal sovereignty rights. And when we're also empowering voices at the table, that it's important that we keep true to what we have stated, that tribal programs and organizations, their funding is at a particular capacity, and that means that they are wearing multiple hats. So we have to come, when we engage with them, it is relevant, and we provide reciprocity with our ask, and it has to benefit everybody else.
Yeah, and just to add to Kim's comment, whether that's monetarily or otherwise, we do our best to make sure that reciprocity, which is an indigenous concept and very internal to the culture, that we make sure that it's beneficial to them. And again, Kim, talking about diversity, we make sure to acknowledge that we recognize that there are vast differences in experiences, not only across people, but we talk about tribal members living in tribal areas, but also the urban American Indian Alaska Native population, and recognizing that those are, although they all fall under American Indian Alaska Natives, but they experience things differently, and we need to make sure that we are making sure that that's seen and heard at those tables.
Thank you all. This was fantastic. I want to thank our speakers, Kimberly and Gerard, so much for presenting. And I want to thank all of you for attending this session. We're going to let out a little early, unless anyone has any remaining questions. So just a few short announcements. So slides and any additional handouts that the speakers have provided are currently available on SCED. You will receive a conference evaluation form via email after the conference is over, and that will be posted tomorrow. So please make sure that you fill that out, even if you've only attended a portion of the conference. We really appreciate your input because it definitely helps shape next year's conference. We will be picking up. So today was the last session. Take a breather. We'll be picking up tomorrow morning, bright and early at 9 a.m. With a new offering. It's our 2025 Lightning Talks, which features 6 5 to 7 minute presentations about the future direction of public health and how it's impacting these innovations, how they're impacting social justice and health justice. We really hope to see you all there, and for the additional breakout sessions, which will be held afterwards. And then please make sure to check out SCED for the full schedule. Thank you all so very much, and happy Thursday. Bye all.